The subcommittee hearing will be called to order, and today we are having a hearing on the James Zadroga 9/11 Health and Compensation Act of 2009. First of all, let me say good morning to our colleagues who are at the desk there, and to all of you who are here. I know how important an issue this is, not only to the New York and New Jersey delegation, but I think also nationwide. The bill was introduced by Ms. Maloney, Mr. Nadler, and Mr. King. And again, I want to thank you for all that you've done on this legislation. I think actually in my opening remarks I mentioned the hearing that Jerry had, that Mr. Nadler had within maybe a month or so of the World Trade Center attack. And I remember going to the Federal Building, I think it was at the Federal Building in New York, and you were bringing up, you were sort of raising all the issues that at the time were being denied by the EPA, and it turned out to be true. So it's often the case with Mr. Nadler that he brings issues to the attention that the agencies deny, and then it turns out that he was absolutely right from the beginning. Last year, the subcommittee had 2 hearings on this issue to examine medical monitoring and treatment programs for those affected by 9/11 diseases, and a legislative hearing on a similar bill to the one before us today. Both of these hearings provided us with vital information on this issue. 8 years ago, as we all know, our country was struck by a horrible tragedy. People lost their lives, families were shattered, and our nation responded. And individuals from all over the country rushed to the aid of those in need, not stopping to think about the effects on their health or lives. I know I'll never forget those horrifying days. I was at the World Trade Center site with President Bush. I think the attack occurred on Tuesday, and we were there maybe Friday of that week. And I saw firsthand the dedication and determination of the rescue workers and the volunteers who pushed themselves to the brink of exhaustion and beyond. I distinctly remember that when we arrived, I was standing next to a yellow fire truck that was from Hialeah, Florida. And I thought, how did that truck get up here in such a short time? I mean, I guess it's possible to do. But it was people literally from all over the country. In the month following the 9/11 attacks, I mentioned I attended a field hearing with Congressman Nadler in New York City to investigate the presence of hazardous waste and the health implications for those who were exposed. We did not know then if there would be any long-term effects or just how debilitating they would be. But we now have more in-depth understanding of how the dust, the glass fragments, and other toxins released into the air affected both responders and community residents. Studies have shown that individuals present during and immediately after the attack now suffer from new or worsened respiratory diseases, gastroesophageal disorders, and mental health conditions, including post-traumatic stress disorder. We in Congress have an obligation to our nation's heroes and to the victims of these attacks. It's our turn to step up to the plate and come to their aid, and the bill before us today is a vital step in that direction. H.R. 847 would establish a permanent program to monitor and screen eligible residents and responders and provide medical treatment for those suffering from World Trade Center-related diseases. It would direct the Department of Health and Human Services to conduct and support research into new conditions that may be related to the attacks and to evaluate different and emerging methods of diagnosis and treatment. The legislation would build upon the expertise of the Centers of Excellence, which are currently providing high-quality care to thousands of responders and ensuring ongoing data collection and analysis to evaluate health risks. Now, one of these centers, as you know, is located in my district on the Bush campus of Rutgers University in Piscataway and is run by Dr. Iris Udison. It's the UMDNJ World Trade Center Medical Monitoring and Treatment Program, which was established in January 2003 to study, interpret, and treat medical symptoms commonly occurring in responders and volunteers. The center currently, this is the New Jersey Center, currently serves approximately 1,370 patients. I visited the center a few times and have seen the work that Dr. Udison and her team are doing to help our nation's heroes. I know she couldn't be here today. I think she's not in the country, so she wasn't able to come today. But at the center, the in-depth knowledge of these complex conditions is crucial to all their patients, and we must ensure that this program is permanently funded so that they can continue providing this excellent care. So I just want to thank all the sponsors again for your tireless efforts. Mr. Deal and I know how tireless you are, because oftentimes a week does not pass by without you mentioning this issue on the floor. We want to thank the witnesses, not only our two colleagues, but those who will be on the next panel, in particular Mr. Torres, who's from New Jersey and who was one of the first responders to the 9/11 attacks. We're going to be hearing his story today, and on behalf of everyone, I want to particularly thank you also for being here. And I'll now recognize the ranking member, Mr. Deal.
Thank you, Mr. Chairman. Thank you for holding the hearing, and thanks to our two colleagues for being on the first panel. I think we all understand the significance of the events of 9/11, and as we explore this bill, H.R. 847, we understand the long-term consequences in terms of health to those who rush to the aid of others and to the consequences that they have suffered as a result of it. My only regret is that, and I have to tell my colleagues as well as the other panel members, this just happens to be at the very same time that we're holding a full committee hearing on climate change of the Energy and Commerce Committee. And for those such as myself who are on the full committee but are not on the Energy Subcommittee, this is the only opportunity, this hearing that's going on right now, to participate in that particular important discussion. So I think that accounts for the fact that you probably will not have very many members here because of the full committee hearing on that important issue going on simultaneously. Wish it would have been otherwise, but we deal with the time constraints that we have. The hearing today, of course, is to assess the current monitoring and treatment efforts that have been provided to individuals who were involved in the 9/11 catastrophe and to those who were within proximity to the World Trade Center on 9/11 and the weeks and months that followed. It is my understanding that to date the federal government has allocated approximately $1 billion toward monitoring and treatment of first responders. Although this legislation has yet to be scored by the Congressional Budget Office, CBO estimated last year that the impact of similar legislation, which was H.R. 7174, upon which the subcommittee held a legislative hearing last summer, that it would cost taxpayers over $11 billion within a 10-year time frame. If the majority intends to move this legislation out of the committee for a vote, I hope that members on both sides of the aisle will be given the opportunity to hold another legislative hearing to receive the expert input from CBO regarding the true cost of the legislation. I look forward to continuing to work with the members of the committee on this, and once again thank my colleagues for their interest and their attendance here today. I yield back.
Thank you, Mr. Deal. And let me reiterate what Mr. Deal said about conflicts today. Actually, Lisa Jackson, I think, was our New Jersey commissioner, now is the EPA administrator, is, I think, testifying this morning on, on the global climate change in the full committee. So we're missing that. I appreciate the fact that Mr. Engel is here, but you're doing something with Hillary Clinton this morning, aren't you, in your other committee?
The Foreign Affairs Committee has a full hearing with the Secretary of State. First time she's appearing before any committee, either in the House or the Senate.
So there's a lot going on, so forgive us. But even with that, Mr. Engel's here, and I want to also acknowledge his significant involvement in this legislation as well. Thank you, Elliot.
Well, thank you, Mr. Chairman, and I want to thank you for holding this hearing today, because you and I have had many talks about the importance of the 9/11 Health and Compensation Act, and I appreciate your willingness to hold a hearing in the midst of all the committee's work on many things, but particularly on health reform. So I'm glad that you're chairing this important subcommittee, and thank you for really doing this. I'm also delighted to see my colleagues, Jerry Nadler and Pete King, both of whom I have firsthand knowledge, being a colleague of theirs from New York, of the work that both of them have done in focusing on this very important issue of 9/11 health care, the 9/11 Health and Compensation Act, and all the other things relating to the devastating attack on September 11th, 2001. In particular, Mr. Nadler, the World Trade Center and the attacks are in his district, and he has played a front and center role on all these issues, not just on the health issues, but on all the issues pertaining to the attack. So I want to thank Mr. Nadler and Mr. King for being here this morning. you know, as devastating as that day was, there are a few days I've been more proud to be an American than on September 11th. I said that in my first statement on the House floor a day or two after the attacks, where I spoke from the heart, not by reading anything. Within minutes of crashes into the Twin Towers, New York's first responders mobilized to save those trapped within the World Trade Center, putting themselves in unspeakable danger. And of course, too many lost their lives that day. Within days, over 40,000 responders from across the nation descended upon Ground Zero to do anything possible to help with the rescue, recovery, and cleanup. I remember those bittersweet days. I was there in New York City, where I was born and bred. I happened to be in New York City on September 11th, and remember seeing Americans lined up around blocks to donate blood. That Friday, the attack was on a Tuesday. That Friday, the New York delegation stood with President Bush at Ground Zero, that very famous picture of President Bush with the firemen and the bullhorn. We were all there right by his side. Particularly Mr. Nadler, I remember, flew in the helicopter that day. There were things we all remember. I remember the chaos, as no one knew quite what to do, only that we had to do something, anything to help our nation rise up from the assault by the terrorists. I was very, very proud to be a New Yorker that day. The past 7 years, though, have not been kind to so many of the first responders who put themselves in harm's way. It's estimated that up to 400,000 people in the World Trade Center area on 9/11 were exposed to extremely toxic environmental hazards, including asbestos, particulate matter, and smoke. You know, it's a funny thing. We kept, those of us in the New York City delegation, we kept going back to the World Trade Center, the devastation, while we saw people running around. And, you know, they gave us these little kind of helmets. None of us wore them, and we kept going back. We were assured at the time by Christy Todd Whitman that everything was fine. And so even those of us in Congress were exposed to these things. I'm not saying that we were exposed the way the first responders were, who were there every day, but we were there, you know, half a dozen times or more, and we were exposed to it as well. Years later, the exposure, though, to the 400,000 people has left a significant number of first responders with severe respiratory ailments, including an asthma rate that is 12 times the normal rate of adult-onset asthma, lung disease, and persistent cough. Also common are PTSD and depression. This has all been well documented in the scientific peer-reviewed published work regarding the long-term health effects of 9/11 by Mount Sinai Hospital, the Fire Department of the City of New York, and the World Trade Center Health Registry. We really don't know the long-term effects of exposure to the toxins from 9/11. Many of us fear that they may be significant late emergent diseases, both in our first responders and members of the community, such as cancer, that will require treatment for years to come. While these illnesses should sadden all of us, what pains me most is that our nation has failed to provide our first responders and community members, Mr. Nadler's constituents, with a sustainable and reliable source of federal funding for a health care monitoring and treatment program. The GAO has documented the failure of HHS to provide consistent care in multiple reports. It certainly sends a chilling message to those who fearlessly volunteered for our country that nearly 8 years later they are still fighting for medical care that should just be a given. So I'm proud to join with my New York colleagues, led by Representatives Maloney, Nadler, and so many others, in introducing the 9/11 Health and Compensation Act. This comprehensive bill would ensure that those exposed to the Ground Zero toxins have a right to be medically monitored, and all that are sick have a right to treatment. It would also rightfully provide compensation for loss by reopening the 9/11 Compensation Fund. No more fragmented health care, no more excuses. We must and shall do what is right, and I thank you, Mr. Chairman, for bringing this to the fore, and I thank my colleagues, Mr. Nadler and Mr. King, for coming here today. I yield back.
Thank you, Mr. Engel. We're going to now turn to the first panel, and obviously very pleased that you're with us here today and all that you've done. I guess I should mention, I think we already mentioned it, that Representative Carolyn Maloney could not be here because she has a bill, I think, one of her other bills that's being marked up credit card bill, another important bill that is being marked up. But we have her statement, so without objection, I'll ask unanimous consent to submit that for the record.
Mr. Chairman, I would also ask unanimous consent that members of the committee be given 5 days in which to submit their statements for the record in this hearing.
Without objection, so ordered. We're going to start with Congressman Nadler.
Well, thank you, Mr. Chairman. Mr. Chairman, Ranking Member Deal, members of the subcommittee, including my fellow New Yorker, Mr. Engel. Thank you for convening this hearing and inviting my colleagues and me to testify before you this morning. I also want to thank everyone who's worked on this bill to help us achieve our longstanding goal of providing a stable, long-term program to help the responders, the residents, area workers, students, and others who were injured by the attack on our country on September 11th. Representative Maloney and I, along with Representatives King and McMahon, have introduced H.R. 847, the 9/11 Health and Compensation Act of 2009, to ensure that the living victims of the September 11th terrorist attacks have a right to health care for their World Trade Center-related illnesses and the route to compensation for economic losses. Now, as many of my colleagues know, and as many of us sitting in this room know, today's panelists have come together many times since the towers fell almost 8 years ago, holding press conferences, testifying at hearings, and releasing countless pages of information detailing the environmental impacts and health effects created by the attack on the United States. For 8 years, those of us here today have testified about the toxins that were inhaled by those near Ground Zero in the days and weeks following the attacks. We warned then that the air wasn't safe and that our courageous first responders were not being afforded the proper protection from dangerous toxins as they were working on the pile. But the EPA, the federal EPA, kept assuring everyone, wrongly, that the air was safe. We spent years working to try to convince public officials that the asbestos, fiberglass, mercury, manganese, and other toxins had traveled far and settled into the interiors of residences, workplaces, and schools, and that a proper testing and cleanup program was required to eliminate the continuing health risks to area residents, workers, and students. We demanded that the government acknowledge the fact, supported by a mountain of peer-reviewed research, that thousands of our nation's citizens are today sick because of 9/11, and that many more will likely become sick in the future. We explained to whoever would listen that our 9/11 heroes were struggling to pay health care costs because they could no longer work and had lost their health insurance, or because they had had their workers' compensation claims contested. We have argued vigorously that the federal response to date has been dangerously limited, piecemeal, and unpredictable, both in terms of preventing further health impacts from potentially persistent indoor contamination, and most notably in terms of a lack of comprehensive long-term approach to providing health care and compensation for those already affected. Yet each time we presented our case for a comprehensive solution, we were told better luck next year. Well, a new year has come, and we are here again on behalf of those who continue to suffer. Undaunted and due to considerable efforts by all of the stakeholders, we have modified the bill to achieve what have been our dual goals from the beginning. One, to establish a stable long-term approach that builds on successful existing programs to provide much-needed care for those who are affected by the attacks, regardless of whether they are first responders or area workers, residents, students, or others. And two, doing this in a fiscally responsible manner. We are hopeful that today's hearing marks the beginning of the end of our collective 8-year struggle. We are hopeful that this is the first step in finally passing this critical legislation to give those men, women, and children who live with the daily reminders of that terrible day in 2001 the support and care they deserve. Although the devastating 9/11 attacks on the World Trade Center occurred within the bounds of my congressional district, it was our nation as a whole that was attacked, and the ramifications stretch well beyond the bounds of my district or indeed of New York. Every member in New York's downstate delegation represents hundreds, if not thousands, of people who live, work, attend school, or were otherwise present in Lower Manhattan and the affected parts of Brooklyn and were exposed to the toxic brew in the air. But it doesn't end there. Because people from all across the country came from New York City to help, there are now citizens in every state, in fact in 431 congressional districts that we know about, 431 out of 435, who were exposed to the toxic fumes of 9/11 and who were concerned enough about it to register with the World Trade Center Health Registry. So this is not just a problem for members from New York and New Jersey. This issue should concern every member of the House. Because this is unquestionably a national problem, it has always required a national response. Yet the previous administration declined to develop a comprehensive plan to deal with the growing public health problem, forcing the New York delegation year after year to come to Congress to test its luck during the annual appropriations process. Thankfully, with growing bipartisan support for that funding, we have had some key successes. And with those funds, we have seen some critical first steps in federally funded health care programming. But quite simply, this disjointed and unpredictable approach to securing critical funding is not a tenable course of action. Both our heroes and the excellent health care programs that are now in place to serve them deserve better. Passage of the 9/11 Health and Compensation Act would mark an end to this problematic approach and ensure that a consistent source of funding is available to monitor and treat the thousands of first responders and community members already affected by World Trade Center-related illnesses, as well as those whose illnesses may become apparent in the future. And it would ensure that no matter where an affected individual lives in the future, he or she could get care. Building on the expertise of the Centers of Excellence, the bill would fill gaps in how we are currently providing treatment and monitoring. The bill would also provide for substantial data collection regarding the nature and extent of related illnesses. This is a particularly critical provision as there is still much we have to learn about these illnesses and how they affect different exposure populations. And finally, as you know, this legislation would provide an opportunity for compensation for economic damages and losses by reopening the 9/11 Victims' Compensation Fund. As you'll hear from the other panelists, the needs here are abundantly clear. About 16,000 first responders are currently being treated for illnesses, and about 40,000 more, and more than 40,000 are being monitored through a consortium of providers led by Mount Sinai Hospital and the New York City Fire Department. And we already have nearly 3,400 sick community members being treated by a program funded in part by the federal government, the World Trade Center Environmental Health Program at Bellevue Hospital. As you may know, the bill has been modified several times in order to ensure that those in need receive the care they deserve and that the cost is feasible and responsible. First, the bill limits the radius, the geographical radius within which individuals who reside, go to school or work, would be eligible for services. Second, it caps the total number of new treatment slots at 35,000, which incidentally is the same level as the responder program. Finally, the bill creates contingency funds with strict dollar limits and caps other kinds of spending. Today, every member of this subcommittee has an opportunity. You can decide that you are going to join with those of us in this room who have been fighting for this funding for 8 long years, and with those back in New York and throughout the country who continue to grapple with the consequences of the 9/11 attacks. With your help, we can finally give the heroes and victims of 9/11 the peace of mind they deserve by providing for their health needs and other losses. I urge you to please join us in supporting the 9/11 Health and Compensation Act and helping us to move this important legislation forward so that it can be finally brought to the whole House for a vote. Thank you again, Mr. Chairman and members of the subcommittee, for holding this hearing, and I look forward to the testimony of my colleagues and other witnesses today. I yield back the balance of my time.
Thank you, Congressman Nadler. And next is Congressman Peter King. And again, thank you for your major efforts on this legislation. And of course, you also make it bipartisan, which is very important. Thanks.
Thank you, Mr. Chairman. I want to thank you and the ranking member for holding this hearing today. Obviously, I see Congressman Wiener's here, Congressman Engel, who know firsthand just how devastating this attack has been on New York and New Jersey, but as Congressman Nadler said, on the entire nation. Also, let me commend Jerry Nadler and Carol Maloney, because they really have been there from the start. And if I could just add one humorous note on a very serious issue, passage of this bill will protect so many members on the House floor from being accosted by Jerry Nadler. Because for 7.5 years, if he spots anyone standing still, he comes up to them and urges adoption of this bill. So there's a very selfish interest in passing this legislation. But seriously, Congressman Nadler and others have worked so hard on this because it is such a vital issue. And it's really an issue whose time has come, and actually came many years ago. And there really is no excuse at all for going further with this. And on a bipartisan note, I am Republican on this bill, but also Dr. Burgess on your committee has been very helpful. And I know he strongly supports this bill. I saw him this morning, and he asked me to point that out. What Congressman Nadler said about the thousands and thousands, and what, also Congressman Engel, of first responders who went to the scene that day and stayed there for the next 8, 9, 10 months, I mean, day in and day out, working, in some cases, almost around the clock, and at the time, without any real concern for their safety. They just wanted to get the job done. And when the time limit for the Victims' Compensation Fund expired, most of these people had no idea of the underlying illnesses that they had. But we've seen thousands coming forward. I mean, so many firefighters I know have serious pulmonary illnesses, men who were really in the prime of life, absolutely perfect physical condition. Now some of them can barely breathe. And you just see the impact it's had, and it's all come in the last 2, 3, 4 years. Just the other night, this is anecdotal, but I happened to be at an event. There were 2 police officers there, and they did not even work around the clock at the World Trade Center. They were there the day of the attack, and they were in charge of bringing dignitaries and government officials to the site over the next 6 or 7 months. They both have come down with the same type of serious sinus disorder. And, you know, the odds are of that happening, of 2 people being struck with that type of, and it's a rare type of sinus disorder. So I just say that anecdotally, and there's so many others, stories like that we hear, and there was really no reason to delay this any further. We have an obligation to the country, we have an obligation to those who came forward, we have an obligation to the contractors who also put a lot on the line when they came down there. And, you know, it happened in New York now, it could happen in any other state in the country at any time. And I believe when a situation like this happens, it's imperative and it's incumbent upon the country to come together. And as Jerry said, 431 congressional districts in this country have been affected by this. And I would just hope that people not see this as a New York issue or a New Jersey issue or a Northeast issue. It really is an American issue. And also, as Congressman Nadler said, this bill has been refined. It has been, I think, finely tuned. But if there is any specific objection anyone has, a question, I would just ask we resolve that and not put this on the back burner again and not come back to it next year or the year after. We are so close to the the finish line right now, so close to getting this done. And it would really, I think, be outrageous and disgraceful not to complete the job and not to get it done. We owe it to those who were there that day. Jerry, of course, knows firsthand the people in his district who suffered. But as I said, in the entire region, entire country, so many others who put their lives on the line and did it unquestioningly. They deserve this type of response, and we owe it also to future generations, if God forbid something like this should ever happen again, to let people know that America does stand by those who respond to the call of duty. So with that, I thank you for holding this hearing today, and really also thank the men and women who are here to testify, the men and women who have done so much, and the men and women who have really never stopped sacrificing for their country, and unfortunately are still suffering because of that sacrifice. And with that, I yield back. Thank you, Mr. Chairman.
Thank you, Congressman King. Thank you both. We normally don't ask questions of our colleagues, so unless someone objects, I'm going to move on. But thank you so much, really. And you know, we do intend to move the bill. I mean, we're not just having a hearing, as you know. So appreciate
Thank you, Mr.
it.
Chairman.
Thank you, Mr. Chairman.
Thank you, Nathan.
Could the next panel come forward? Where are the name tags? We'll get the name tags so you know where to sit, but I guess it doesn't matter. You could sit wherever you like. Oh, we're missing a chair? You have to come up. We'll get you another chair. Yeah, Mr. Torres, sorry. I don't know what happened to the name tags, but hopefully we'll have some. Oh, there's a problem with the printer. So I think we're going to start without the name tags. Can we remove the ones that are there? Oh, he's going to do it, Charlie? Oh, jeez, thank you. Thanks, Charlie. Thank you. All right. They may not be oh, here we go, okay. Now, I will warn you that you're not sitting in the order that I have, so I am going to follow the order I have in terms of your testimony. So let me at least introduce each of you, and the way I introduce you is the order that you're going to speak. Okay. First is Mr. Eduardo Torres from Jersey City, who's over on my right, and then there's Dr. Jacqueline Moline, who is Vice Chair, Community and Preventative Medicine Director of the WTC Medical Monitoring and Treatment Program Clinical Center at Mount Sinai, and also director of the New York, New Jersey Education and Research Center at Mount Sinai School of Medicine in the city of New York. Then we have Dr. Joan Reibman, who is Associate Professor of Medicine and Environmental Medicine, Director of the NYU Bellevue Asthma Center, and Director of Health and Hospitals Corporation for the World Trade Center Environmental Health Center at Bellevue Hospital in New York City. And then we have Dr. Jim Melius, who's Administrator for the New York State Laborers Tri-Funds in Albany, New York. And finally is Caswell Holloway, who's Special Advisor to New York City Mayor Michael Bloomberg and Chief of Staff to New York City Deputy Mayor for Operations Edward Schuyler. Long resume here for many of you. I think, you know, it's 5 minutes opening statements. We're going to try to keep to that if possible. And if you want to submit, testimony for the record, we will do that as well. And then we'll have questions after by members of the panel. And we'll start with Mr. Torres. Thanks for being here. Oh, you need a mic. Mr. Holloway, just turn that way and then just press the button till the light comes on there. That should do it.
Okay.
Maybe move it a little closer to him. It might be a little, yeah.
How's that? Can you hear me?
Yeah, even a little closer.
Okay. How's that?
That's good.
Okay. Thank you, Mr. Chairman Pallone, members of the committee. Good morning, and thank you for the opportunity of testifying before you today. My name is Eduardo Torres. I'm 47 years old, and I'm a resident of Jersey City. I'm a construction worker and a trade member of the Plumbers Local Union 14 AFL-CIO based in Lodi, New Jersey. I'm testifying before you today in support of the James Zadroga 9/11 Health Commission Compensation Act of 2009. I come before you this morning as a citizen, wanted to do my part to assist the victims of 9/11 terrorist attack of the World Trade Center and assist the responders. But now I'm suffering from serious health effects due to the exposure of Ground Zero's toxics and the breathing of the toxics and the pulverizing building materials. My story begins on September 2001. I arrived at Ground Zero from New Jersey at 11 a.m. Workers were being recruited from my job site and my local union to assist the rescue efforts. Upon arriving to Manhattan from New Jersey, I immediately began to assist the police, firemen, and rescue attempts as possible survivors trapped in the rubble of the World Trade Center and to move debris from the pile. I was assigned to the Bucket Brigade, which slowly was painstakingly removing debris from certain areas via a long line of people passing one bucket after another, and I performed this task up to 8 p.m. that evening. I returned to the pile on September 13th, 14th, and 15th, and over the course of those 4 days, I performed the same exact task for approximately 60 hours. The first day on the pile, I wore a simple dust mask and a hard hat. 3 following days, I wore a 2-canister filter respirator and a hard hat, though at this time we dug on the pile by hand because shovels simply didn't work well. We entered a time when we filled up the buckets and we were instructed to carefully shift through reviewing the material and attempt to identify remains. Although the environment of working was surreal, the weather was actually couldn't have been nicer out. It was clear, sunny, and shiny. The first day, the level of dust that appeared on the naked eye had been reduced. Although the smoke and the smell of the fumes intense at times, there was a false sense of security and the frenzied dedication of the workers, sometimes forcing us to remove our respirators. We also removed them when we ate or drank water, both in which occurred right on the pile. I was completely unaware of the health hazards presented in the air, and although the dust appeared to be minimal, I would be reminded of the massive amount of dust in the air when I washed my face on an hourly basis. And when I would dry with a paper towel, I would see heavily gray cover on it. I wiped massive amount of soot from my face on a regular basis. When I went to Ground Zero on September 15th, I was proud I was proud to volunteer, and I once with all my energy, and I had over the last 4 helping victims in the attack. That day was the last day that I went to volunteer at Ground Zero. I returned to my home that Saturday, and I attempted to go back to the Powell on September 16th, but there was no longer running ferries from New Jersey, and much of the workers, with less volunteers, were being recruited. I returned to work on Monday, September 17th. An important note, I never had any health problems prior to 9/11. In fact, I consider myself to be in great shape. I jogged approximately 3 times a week, and I never had any problems breathing. For the first 4 months after 9/11, I had no symptoms of health problems of any kind, and changing within described again and off again sore throat, starting from February of 2002, in which I would lose my voice on occasion. 2002, I started having stomach pains, not comfortable, but pains similar to a worse type of acid reflux or heartburn, and I had stomach problems at all prior to 9/11. This persisted and continued worse in the course of the next 3 years. 2005, my throat, my stomach problems were consistently more problematic at the time of receiving a physical at March of 2005. The worst came into November of 2005, in a period of lengthened that time, I could no longer walk up more than 1 flight of stairs. Work was becoming much more difficult. The winter, I lost about 6 or 7 days of work because it was too cold or the weather, just simply I couldn't breathe. In fact, at one point during a dance performance, my chest pains and the ability to breathe forced me to stop performing. There are days that I couldn't even run with my kids, participate in sports, or sleep cycles have become disturbing due to my respiratory problems. The only medicine that I had at this time was the reflux system gotten worse, and at the time I visited a lung specialist who performed a PET scan. On March 2006 and October of 2006, I was diagnosed with having nodules of lungs and recruited a lung epoxy and lung scarring. The doctors, however, did not say it was a result of my exposure. After finding this problem, I recognized my opinion that they were a result of my working at Ground Zero, and I decided to attend Mount Sinai World Trade Center Medical Monitoring Program for an examination, which accepted into the program in May of 2006. At this time, I was diagnosed to the World Trade Center related conditions, gastroesophageal reflux disorder, GERD, and chronic respiratory restriction. By treatment, I began at this time, and I was taking prescription medicine, and the treatment consisted of throat pains that I was suffering. Eventually, I had surgery, which was paid for by the Medical Monitoring Fund of October 2006, and the surgery removed a mass or polyp on my throat, and it was not cancerous. After the surgery, I was out for 6 weeks of work. I found the caregivers of the World Trade Center monitoring program to have a very compassionate. I was also, unlike my first doctor, they had the thought, understanding, and context in which the medical examiners treated us were required. These caregivers understood the 9/11 Association and however to treat these problems specifically. The program also performed an extensive breathing analysis of a PFT test, pulmonary function test, every 3 months, and I received a checkup, a CAT scan, and I met with doctors. Since May of 2006, I have been to the program 24 times. The program pays for the treatment and the monitoring My insurance, though, through my union, pays for the CAT scans. I have never paid anything out of pocket, with exception of prescription drug co-payments, and they have a program in Piscataway, but the one in New York City becomes a shorter drive for me. Under the James Zadroga 9/11 Health and Compensation Act of 2009 legislation, I will continue to receive medical monitoring since both of my diagnosis conditions are on the list of identifying the World Trade Center conditions specifically in this bill. This would allow me to continue the course of the medical treatment paid for, but which also would assist others, effective workers who are currently struggling. For workers like me, with participating in this program and monitoring the treatment essential. Furthermore, under this bill, we would allow to receive non-treatment core service such as education of my condition, counseling, advising on how to identify and obtain benefits if needed, workers' compensation, health insurance, insurance, and public, private, and social service agencies. In closing, I would like to repeat a question a nurse gathering research from me had asked at Mount Sinai Hospital, and ask you to put this in context as you deliberate this legislation. I was asked on August 2008 during a checkup in a monitored program if I understood the health effects resulted from your ground zero volunteering, would you still have gone? And I responded yes. Before she could even have a chance of finishing the question, despite all the pain that it has caused me, I would not have changed a thing. Those people needed me, my country needed me. I had to do the right thing. And now, respectfully, I ask you to respond to the health needs by also saying yes when this bill comes up to vote. So yours, thank you.
Thank you, Mr. Torres. Thank you for relating your story, which I'm sure is very much like what a lot of other responders have been going through. Thank you. Dr. Moline?
Chairman Pallone and Ranking Member Deal and members of the committee, I'd like to thank you for inviting me to present testimony today. My name is Dr. Jacqueline Moline. I'm an occupational medicine specialist at Mount Sinai School of Medicine in New York City, and I direct Mount Sinai's Clinical Center of the World Trade Center Medical Monitoring and Treatment Program. We're the flagship of a regional and national consortium that's supported by NIOSH, the National Institute for Occupational Safety and Health, through February 28, 2009, has diagnosed and treated nearly 27,000 World Trade Center responders throughout this country. I'm here today to testify in support of H.R. 847, which in my view is the best vehicle to meet the need for continued medical care of the responders and ensure that the 9/11 responders receive the high-quality medical care they rightfully deserve. On or after September 11, 2001, an estimated 60 to 70,000 traditional first responders and not so traditional responders came from every state in the nation, including tens of thousands from the New York metropolitan area, working for days, weeks, and months in around Ground Zero. Their hard work and bravery got New York and our nation back on its feet, and we owe them tremendous gratitude. They were exposed to a complex and unprecedented mixture of toxic chemicals, including dust, glass shards, and carcinogens like benzene, asbestos, and dioxin. The collapse of the towers in the morning and then a third building in the afternoon created a dust cloud, turning a bright sunny day into night. The pulverized cement had a pH equivalent to lye. Fires burned for 3 months. Removal operations lasted through May 2002, repeatedly exposing these workers to dust. In addition to the physical exposures, they had extreme psychological stress. They came upon human remains. The stress was compounded by fatigue as they worked hour after hour, day after day. Among those most affected have been the non-traditional responders, those not trained for any emergency, let alone a disaster the scale posed by 9/11. Mount Sinai, through its Center for Occupational and Environmental Medicine, designed and developed what stands today as the federal government's health response to 9/11, a model based on experience and expertise of academic physicians with specialty training in occupational medicine, surrounded by specialists in various disciplines. Our regional consortium of clinical centers of excellence in New York and New Jersey, together with the national program that initially was coordinated by Mount Sinai and is now coordinated by LHI, has provided 46,858 monitoring exams to 26,651 responders in all 50 states. Mount Sinai alone has provided over 30,000 of these exams to over 17,350 responders. Since the New York and New Jersey Metropolitan Area Consortium treatment programs began, we have provided nearly 90,000 physical, mental, and social work services in our consortium. Even now, approximately 150 new eligible responders join our program every month. Many of these responders continue to suffer health effects with attendant social and financial effects. We've seen asthma, sinus problems, GERD. Breathing tests still are abnormal in 25% of our patients. Mental health consequences are at rates seen in our returning veterans from Afghanistan. If we look at 6 months of conditions in approximately 4,400 patients undergoing treatment in our programs, we see GERD or reflux in 53%, 35% have mental health problems, lower respiratory conditions in 46%, upper respiratory conditions in 69%, social disability, no health insurance in 22%, and 64% have multiple medical conditions. Some have responded, but thousands have received treatment and still require care. One of my patients, Mr. S., is a carpenter. He worked for a New York City agency and was in great health, never had a health problem, never had shortness of breath. He developed GERD, reactive airways, sinus problems, anxiety, couldn't work in a dusty environment, and thus could no longer be a carpenter. He lost his health insurance, fell behind on his bills, couldn't obtain workers' compensation because they controverted his case. He couldn't afford medication, his necessary tests. Through this program, he's receiving the care he needs and his health is stable. It's not back to normal, he can't work anymore, but at least he's able to care for himself and his family. We know that new conditions, those marked by longer latency, will emerge among 9/11 responders since they were exposed to carcinogens, neurotoxins, and other chemicals toxic to the respiratory tract in concentrations and combinations never before encountered. The future health outlook for responders remains uncertain, and the long-term consequences of an unprecedented mixture of toxicants is not known. All of us must remain vigilant for these problems. Through the medical findings I've summarized this morning and the persistence of illness that we're seeing in a substantial number of responders, we must have stable, predictable federal funding for a medical program for the responders. We establish these programs, we have established ties with our patients, gained their trust in our care for them, and we hope to continue doing this without interruption of care. We're also coordinating data. This is the only way we're going to know what has happened to the 9/11 responders. We, in real time, collect data on the outcomes, looking for medical trends, patterns of disease. We can assess the efficacy of treatments. We can inform the medical community, the scientific community, and the legislative community of these findings. We disseminate these regularly in medical journals, and this will provide essential guidance in helping us in any future disasters. All of the good work is impossible without the centers of excellence. We're providing state-of-the-art medical care to men and women who risked everything for us in a time tantamount to war. Our goal in these programs is simple. We want to provide the best care possible to these men and women and not worry we won't be there if they need care for World Trade Center-related diseases. Passage of H.R. 847 will ensure that the heroes of 9/11 are never forgotten. Thank you.
Thank you, Dr. Moline. Dr. Reibman is next.
Good morning, Chairman Pallone, Ranking Member Deal, members of the committee. My name is Joan Reibman, and I'm an Associate Professor of Medicine and Environmental Medicine at New York University, and I'm an attending physician at Bellevue Hospital, a public hospital on 27th Street in New York City. I'm a specialist in pulmonary medicine, and for the past 17, almost 18 years now, I've directed the NYU Bellevue Asthma Center. And I'm pleased today to be able to testify on behalf of the local workers, the residents, and the students of downtown New York who were exposed to World Trade Center dust and fumes. I'm very pleased to be here today to support H.R. 847, the James Zadroga 9/11 Health and Compensation Act, which will provide needed long-term funding for the monitoring and treatment of those members of the community exposed to toxic substances as a result of 9/11. Many of these individuals, unfortunately, have become patients with long-term health needs related to respiratory as well as other physical and mental health illness. Let me talk a little bit about populations at risk. You've heard a lot about the heroes who helped in the recovery of our city and our country. I would like to tell you a little bit about the people that we serve, the local workers, residents, and the students exposed to the World Trade Center dust and fumes. On the morning of 9/11, about 300,000 individuals were at work in the area or in transit to their offices. Many were caught in the initial massive dust cloud as the buildings collapsed. We now call these people the dust cloud people. These are the thousands whom you saw in the videos and the still photographs coated in white, running for their lives. In the great outpouring of pride and patriotism after 9/11, many local workers returned to work 1 week later, the massive World Trade Center cleanup and rescue operation still in full force, and not all the buildings completely cleaned or decontaminated. As you also know, Lower Manhattan is a dense residential community. Almost 60,000 people of diverse race and ethnic backgrounds live south of Canal Street. They're economically diverse, some living in large public housing complexes, others in new co-ops. Lower Manhattan is also an educational hub. There are almost 15,000 or more school children, large numbers of university and college students. Many of these students were locked in their building, others were told to run for their lives. The dust of the towers settled on streets, playgrounds, cars, and buildings, entered apartments, schools, and office buildings through windows, building cracks, and ventilation systems. The World Trade Center buildings burned through December. Each of these groups had potential for exposure to the dust, both indoors and outdoors, and to fumes from the fires that continued to burn. So what were the initial health effects in these populations? As pulmonologists in a public hospital, we sought to determine whether the collapse of the buildings posed a health hazard, and we worked to monitor the effect on the local residents in collaboration with the New York State Department of Health and with funds from the Centers for Disease Control, and looked at the rate of new respiratory symptoms in the local residents after 9/11. This first study was completed just over a year after 9/11, and the results have been reported in 3 peer-reviewed publications. We were able to document that individuals who lived near the area compared to those who lived away from the area had a more than 3 times the number reported of incidents of eye irritation, nasal irritation, sinus congestion, nosebleeds, headaches, a 3-fold increase in lower respiratory symptoms, including cough, shortness of breath, a 6.5-fold increase in wheezing. These are people who were previously healthy. And this was also associated with an almost 2-fold increase in unplanned medical visits and use of medications prescribed for asthma. Residents reporting a longer duration of dust or odors or multiple sources of exposure had greater risk for symptoms compared to those reporting a shorter duration. Data from the New York City Department of Health and Mental Hygiene World Trade Center Registry further documented adverse health effects in building evacuees, school children, and support our original findings. What do we now know about these populations and their illness? After 9/11, we began to treat residents who felt they had World Trade Center-related illness in our Bellevue Hospital asthma clinic. We then developed a community collaboration and together began an unfunded program. We were subsequently awarded American Red Cross Liberty's Disaster Relief Grant in 2005 to set up a medical treatment program, and a year later we received major funding from the City of New York. In the last year, we have just received our first federal funding support for 5 years for a treatment program from the National Institute for Occupational Safety and Health. Providing 3 years of support. We now have an interdisciplinary medical and mental health program that has evaluated and is treating approximately 3,500 patients. We continue to receive inquiries each week. Most come from local people. However, we have received calls from individuals living in about 20 other states. To enter our program, one has to have a medical or now mental health complaint. We're not a screening program for asymptomatic individuals. To date, our patients are almost equally men and women of diverse race, ethnicity, and many, although not all, are uninsured. Some have never sought medical care. Some have been unable to seek care for lack of insurance. Others have been seeing doctors for years since 9/11 with recurrent bronchitis, pneumonia, sinusitis, or unexplained shortness of breath. As described in an article that we have just published, these individuals, residents, local workers, as well as cleanup workers and the few responders in our program, have symptoms that include persistent rhinosinusitis, asthma-like symptoms of cough, shortness of breath, or wheeze, for which they continue to need care more than 7, almost 8 years after 9/11. 40% have shortness of breath that is at a level consistent with significant activity limitation. 10% have the highest score on a standardized scale of breathlessness used for disability assessment. These are people who report that they were previously working and functional, and many now report that they report that they had been highly physically active, some training even for marathons. Over 50% of our population continues to have persistent post-traumatic stress disorder. There are a lot of questions about this population. What respiratory disease are we treating? We now believe that the exposure resulted in several respiratory illnesses with varied patterns. Many of our patients have irritant-induced asthma. Although we can treat this, these individuals require prolonged courses of inhaled corticosteroids and bronchodilators, sometimes even oral steroids. Many will require these medications for years, if not for life. Others show a process in the lung that may consist of a type of inflammation, a granulomatous process that's like an illness called sarcoid. Others have lung diseases that affect not only their airways or breathing tubes, but also the air sacs that allow for the exchange of oxygen and carbon dioxide. Some have pulmonary fibrosis characterized as scarring or permanent damage in the lungs and are awaiting lung transplants. How do we know whether an illness is World Trade Center induced? We often hear that these diseases are common in the population anyway. How do we know that these people are sick from World
Dr.
Trade
Ryman,
Center exposure?
I hate to interrupt you, but you've basically used about as much time as the others, but looking at your written statement, you're not even halfway through, so I don't know if you could summarize from now on.
I would be pleased to
All right,
summarize.
thank
I
you.
would just like to say that without these centers, we will not understand what we're treating, who we're treating, and how to treat. We would not understand why some people are sick and others aren't. We would not understand if there are going to be late emergent diseases, not only in the responder population, but also in the community population. And therefore, we think it's very important, and we very strongly support this bill that provides support not only for the responders, but also for the community. And I'd like to thank you very much.
Thank you, and I apologize. Your whole written testimony becomes part of the record in any case, but I'm just trying to keep the time to a minimum if we can. Next is Dr. Melius.
Thank you, Chairman Pallone and Representative Wiener. I greatly appreciate the opportunity to appear before you at this hearing this morning. I'm an occupational physician, epidemiologist, currently work for the New York State Labor's Health and Safety Trust Fund in New York, and I also have served for the last several years as chair of the steering committee for the medical monitoring and treatment program. I believe that Drs. Moline and Ryman have already presented a good description of some of the illnesses that people are suffering who were exposed at the World Trade Center. I don't want to repeat that information, only indicate it is certainly remarkable how many of people are. The numbers sometimes get lost when one thinks what a high percentage is both of them have presented here today. We have a lot of sick people, and there are many that are disabled and many that are continuing to need intensive medical care. I'd like to focus briefly on why do we need the federal program and what are some of the features of this legislation that I think why it deserves support here in Congress. We need the federal funding for this program because other funding just is not available. Health insurance does not cover work-related health problems, so they automatically get turned down. That includes Medicare. Many of the people in the community don't lack health insurance. All the problems that I think actually this subcommittee may be dealing with in terms of health care reform. We have major problems there. So those two together, I think, make health insurance provides very limited help for these people. One would think that workers' compensation would be a logical place that would support these kinds of illnesses to the extent that they're work-related it certainly could be. The problem is that workers' compensation is not very good at handling new kinds of illnesses, new kinds of findings, and takes a long time. The average claim takes over 3 years to make it through the system, and then even then it can be contested for many more years if there are changes in treatment regimen, something. The insurer can also contest that. So it is not a system that provides for good medical care, for the kind of intensive medical care that these people require, and one that's complicated and one that's constantly changing as the centers of excellence learn more about that. So I think, as I'll speak later, the legislation provides for some recovery of whatever funding might be available for health insurance or workers' compensation, but that will never be able to provide the kind of comprehensive funding that's needed for these medical programs. So what's been devised in H.R. 47, which I strongly support, is a mechanism that provides where the federal government would provide funding. It's set up so it goes to centers of excellence. Well, why centers of excellence? Because we need centers that, such as the ones that Dr. Ryman and Dr. Moline run, that have significant core of expertise and experience in dealing with World Trade Center medical problems. As we've heard Mr. Torres say, when he first went to Mount Sinai, he finally found a medical care provider that understood his problems, was able and ready to provide the kind of care that he needed. And the Centers of Excellence can do that by seeing large numbers of people with these conditions. They can understand the problems, develop the appropriate treatment, appropriate ways of diagnosing these problems, and they can standardize the diagnosis and care of that. They can also collect the data that's needed to learn not only what's happening to these people, what the findings are, but also are new diseases going to emerge. The list of covered conditions currently in the bill cover those that we know about now, that have a sound scientific basis in the medical literature, the asthma, post-traumatic stress, and other diseases that have been mentioned here. But we may very well see other kinds of illnesses, cancer. We just don't know going forward. By having the data collection in place, we'll be able to recognize those as it appear. There are already studies underway looking at this, and there are mechanisms in the bill, both on an individual basis and on a collective basis, to be able to take care of people with health conditions that aren't yet recognized, but may be. But those would only be triggered if there is significant scientific and medical evidence saying that those conditions should be covered. There are also provisions in the bill that provide for significant oversight by the federal government in all aspects of this program. Certification that people are eligible for the program, certification that they are eligible for treatment, that they have a World Trade Center condition that should be treated, oversight over the quality of the medical care, oversight over the reimbursement for that medical care. And I think a mechanism that parallels other federal programs in terms of providing good oversight of this program. So it's not something that, where the money will be carelessly spent. It'll be very carefully spent and very carefully monitored by the federal government. And finally, it also sets up a mechanism for the recovery from health insurance and from workers' compensation insurers, where that's appropriate, for medical care treatment costs. So if, for example, in workers' compensation, if there's a claim that's been recognized, or if a claim that's in process and eventually gets recognized in the system, there'll be a program in place for the federal government to recover the reimbursement that was already spent, the medical care costs that the federal government has spent. And I think that'll make a significant difference in terms of a fair share from those sources of funding, at the same time without impeding or unnecessarily delaying the medical care for the responders or for the community residents that are in this program. I think this bill, as it's presently developed here, the medical program is excellent. I think it has the right safeguards. I think it would provide excellent medical care, a way for us to provide what these people deserve for the sacrifices they've made to our country, and one that without the federal assistance just would not be provided for them. It's already been going on 8 years, and I think it's time we try to get this program in place on a more permanent basis and provide a good, sound, and excellent medical program for these people. Thank you, and I'd be glad to answer any questions.
Thank you, Dr. Melius. Mr. Holloway.
Thank you. Thank you, Chairman Pallone, Ranking Member Deal, Representative Wiener, and for convening this hearing on this important bill, the H.R. 847, the 9/11 Health and Compensation Act. I also want to thank Speaker Nancy Pelosi and the New York delegation for making it a priority to enact legislation to establish a sustained long-term 9/11 health program. My name is Kaz Holloway, and I'm Chief of Staff to New York City's Deputy Mayor for Operations, Edward Schuyler, and a Special Advisor to Mayor Bloomberg. I was also an Executive Director of a panel convened by Mayor Bloomberg at the 5th anniversary of the attacks to assess the health impacts of 9/11. That report called for sustained, long-term program to provide monitoring and treatment to address the health impacts of 9/11 and for the reopening of the Victims' Compensation Fund. Since that time, Mayor Bloomberg, myself, and many others of the members of the Mayor's administration have traveled here to Washington to make the case for sustained federal funding. In fact, as you may recall, last July I testified before this subcommittee, and it's a privilege to appear before you again. It's also a privilege to appear here with Mr. Torres and these distinguished doctors who are involved in the treatment of these conditions. As the members of this committee know, a tremendous amount has happened since I last appeared before you. In terms of this bill, the city has engaged in extensive discussions with stakeholders, including people at this table, and some of the issues that existed in the prior version of the bill have been addressed. In terms of the city's economic outlook, we are still in the throes of an economic crisis that has resulted in the highest unemployment rate in New York City since October 2003, and a projected budget gap of $3.2 billion in FY 2011 that could grow to $4 billion and more in future years. Mayor Bloomberg has moved aggressively since well before the scope of this current crisis became apparent to save for tough times and cut costs, but even with these measures, the city will have to make deep cuts. I mention these statistics not merely because they are timely, but because the city's finances are severely strained. We must concentrate resources on providing the essential services New Yorkers and visitors to the city need, and on getting the economy running again. With respect to H.R. 847, the version of the bill currently before this committee is an important step forward, and in its broad strokes achieves what the city has long been seeking: sustained funding to treat those who are sick or who could become sick because of 9/11, and it reopens the Victim Compensation Fund so that those who were harmed can be fairly compensated quickly and efficiently without having to prove that the city, its contractors, or anyone but the terrorists were at fault. But there are two important issues that in the city's view must be addressed. First, the bill requires the city to pay 10% of the entire treatment and monitoring costs for anyone eligible under the bill. Based on the best information we have to date, which Chairman Pallone, you mentioned from CBO, Ranking Member Deal, this translates into approximately $50 million per year and $500 million over 10 years. And it's unfair for New Yorkers to bear so much of what we believe is clearly a national obligation. Moreover, particularly at a time when the city is being forced to make deep cuts, including to essential services, this cost share is simply too high. Second, regardless of what the city's cost share ultimately turns out to be, the bill does not give the city adequate oversight of the programs it's expected to fund. This issue can be easily addressed by the inclusion of a right to audit or similar mechanism in the bill, and it should be included to make sure that we can oversee the program appropriately. We're confident that these issues can be addressed before this committee and in this legislative process. And the members of the committee have heard a lot of the detail about the scope and impacts of 9/11, so I won't repeat that except to say that what the mayor's report established when it came out in 2007, I think beyond question, was that this is a serious problem, that people are suffering serious mental and physical illnesses as a result of 9/11, and that additional people continue to get sick. That it is imperative that those people get treated, that there continues to be research to fully understand the impacts, and that the funding be sustained. That's why we're here, and that's what we're seeking. And the research that has come out since the mayor's report, which Dr. Reibman, Dr. Merlin, and others have continued to produce, continues to validate these facts. I just want to mention quickly a couple of programs that haven't been mentioned here today. Most importantly, the FDNY's program, which is also a center of excellence and has involved 14,000 of the firefighters who are being monitored and several thousand who are being treated. In addition to that, with the federal government's assistance, we have also started back in 2003 the World Trade Center Health Registry, which is without a doubt the best source of research that we're going to have, in addition to the clinical research that we get out of the Centers of Excellence, to ensure that we fully understand the impacts of 9/11. Now, the city hasn't waited for federal funding in order to address the needs that we found in our report, and in fact, the city is the primary funder of the Health and Hospitals Corporation Center of Excellence that Dr. Reibman runs. However, this program and many other programs are in jeopardy because the city took up the funding obligation to run these programs based on a need and also on an assumption that the federal government would ultimately come to the table and help us to get fully engaged and cover these costs. That's why it's so important that this bill be passed. As Dr. Milius explained, this bill provides long-term funding and has controls in it that we think are appropriate and ensure that money will only go to those who have actually been affected and are ill because of 9/11, so I won't repeat that. I think to sum up, pardon me for 1 second. To sum up, the bill has important controls. It establishes the long-term funding that the city is seeking and is required to ensure that this problem, which we know is long-term, and we know can't be properly sustained by year-to-year ad hoc appropriations, can continue so that those who were injured as a result of 9/11, which was an attack on the nation and not merely on New York City, can get the treatment they need. And it's important to note when we talk about the registry, and as Representative Nadler and King mentioned in their testimony, this is not just a New York City problem. The World Trade Center Health Registry contains representatives from nearly every congressional district in the country. Ranking Member Deal, there are several hundred from Georgia who participated, and a few from your district, and I'm sure, as you know, Chairman Pallone, many thousands from the state of New Jersey and your district. As I mentioned at the outset of my testimony, there are the two issues that the city believes needs to be addressed and can be addressed in this legislative process. That's the cost share issue and the issue of oversight if the city is going to be expected to fund programs that it doesn't control. And I do want to say importantly, the city is not opposed to a cost share at all. In fact, Mayor Bloomberg fully embraced an earlier version of this bill in which the city was going to be required to pay a 5% share of the centers of excellence that are run by the city, which is the Health and Hospitals Corporation and the One Treating Community members. We think this is important because it gives the city the incentive that is needed to ensure that funds are spent carefully and wisely. However, the share that's in the bill, which could cost New York City taxpayers alone up to $500 million, is simply too high. However, we are hopeful that these issues will be addressed, that we can fully support a bill, and that it will be presented for the President's signature before another anniversary of the attacks passes. Thank you very much, and I'll be happy to answer any questions.
Thank you, Mr. Holloway. Thank all of you. We now are going to have questions from the panel, and since there are only three of us, we may actually have two series of questions. We'll see if anyone else joins us. I guess I'm sort of following up on what Mr. Holloway said in the sense that, if you wanted to be devil's advocate, and I guess I shouldn't be devil's advocate because I'm from New Jersey and I'd like, this to be as robust as possible since so many of my New Jersey residents are impacted. But I guess one could argue, the program exists. Obviously, you've described how effective it is. To my knowledge, nobody's being turned away at this point. What we're really here with this legislation is making a permanent authorization for a program that basically does exist and has been funded for the last few years. And my questions are more along the lines of, why do we need to make it permanent, and is this the time to do it? Part of the problem that we've had with all of this is knowing how many people are going to be impacted, how many disorders are going to come forward. It does seem that as time goes on, there are more people that come forward and more people that are being seriously affected in terms of their health. And if that trend continues, or accelerates, we may have even more people than we anticipate because, you have the caps right now in the program. I guess it's 15,000 responders and 15,000 residents beyond those that are already in the program. So I guess I would start first with Dr. Melius or any of the doctors. You mentioned, I think, that there's a list of identified World Trade Center related health conditions in the bill. Do you expect that those additional diseases will emerge as the World Trade Center related, conditions have more of an impact? And under the bill, how are additional conditions added to the list? Let's at least start with that.
Okay. I think I think we all would expect that there will be additional conditions
Right.
added. I think there are a number under investigation already, and we know that people were exposed to carcinogens and a lot of toxic materials, and so I think looking forward, we would expect some. And the bill, I think, was structured in a way to put the caps in place so that that wouldn't get out of hand. In terms of the list of covered conditions, or wouldn't get out of hand without having to come back to Congress and say, well, this program is going to cover hundreds of thousands of people, then because they're sick, then we ought to rethink how we do this and so forth. In terms of the list of covered conditions, the current list is based on the clinical experience, Dr. Rybin and Dr. Moline and others, plus what has been found in the studies. It's a well-based list, and in the current scientifically sound and review, multiple researchers have made these findings, including some outside the program. So I think everyone's confident in what's on the list. Going forward, there's a mechanism so that to add specific covered conditions, say a type of cancer or something that's seen, one, so there has to be some amount of scientific evidence available demonstrating that it should be covered. Secondly, there's a process where the federal government, NIOSH, would promulgate a regulation to add that condition as a covered on the list of covered conditions. So they'd be required, as with any regulation, to justify it, justify the cost, justify, more importantly, the science that behind that. There's also provisions in there for a scientific advisory committee for the program to also review that information and be involved in making that recommendation.
In terms of where we are, I mean, I certainly get the impression from listening to you, and I know this may be difficult to answer, but I certainly get the impression that as time goes on, we're going to see more people that are affected and possibly worsening conditions. I mean, is that just inevitable because as people age, these symptoms and diseases get worse? Or is it possible, that at some point, that doesn't happen because, time is somehow a healer? I mean, I get the impression the opposite, that we should expect as time goes on that we're just going to have more people and worse conditions.
I'll let Dr. Moline, Dr. Rybin follow up, but I think it's a mix, that there are people newly coming in that develop conditions, but there are also people getting better. In fact, one thing that's been observed in the responders program is that the treatment costs actually appear to be going down per patient on an annual basis because patients get stabilized in terms of treatment and so forth, and number do get better, are able to continue to work and so forth, and some don't, and so there's a balance there. So I don't think it's inevitable that these numbers will continue to get bigger and bigger because some people will recover.
Well, let me just ask.
We just aren't able to predict that accurately.
And then I guess my third question would be, and if you want to ask Dr. Moline answer it, the caps that are in place. I mean, are they based on projections that you're seeing an acceleration of the numbers? I mean, how was that derived at, or is it totally artificial?
The caps are on the responder program. The caps are based on an assessment of how many people we know that would be eligible for the responder program. We know how many people worked at the site, at least within several thousand. So we do that, and we have some, I think, pretty good idea of how many of those haven't come forward yet or eligible and might come forward in the future, and then assumption that they're not going to be any sicker than the people that are already in the program. In fact, they're probably going to be fewer that require treatment. So I think it's unlikely that cap will be reached for the responder program. For the community program, I think we had less experience, and maybe Dr. Ryman wants to comment, but it was trying to say that given the time when this legislation is being passed, given who was coming forward at that time, who we knew at that forward was coming forward that was eligible for the community program, that was a reasonable number that would fit in going forward, and at least would for some significant period of time, 10 years or more, would be legitimately capping the program without denying large numbers of people care. It may need to be adjusted. We don't know. Experience is less there, and do that. So,
Okay. Gentlemen, I'm being a little loose with the time here since there's only 3 of us. I'm not going to clock any of us here. So if Dr. Riebman or anybody else wants to answer some of the questions.
I just want to reinforce what Dr. Milius just said, which is for the community group, we had very little information to go on. We could only go by what we were seeing, data from the New York City Department of Health registry, where we could sort of estimate a burden of illness and also understand that some people would be going to their own physicians. And so it was really, with the information we had at hand, our best estimate.
Okay. Dr. Moley?
And if we look at the responders who are coming in, about 150 are coming in consortium-wide every month. This is down from, in the first 2 years of our program, beginning in 2002 to 2004, we had 12,000 responders.
So you're actually getting less per month instead of more?
We're getting far fewer per month because most people have already in. I mean, the question is, why are some people coming in now?
Right.
Where have they been? And there are a couple reasons. We, first and foremost, many people are very stoic. We also know that in a population that is overwhelmingly male, of the responder population, they tend not to access health care. They don't like doctors. I don't know why.
Stoic is the same as denial, or that's a little different, I guess?
It's both.
Yeah.
It's a nice way of putting it sometimes. But some people, actually what I've often been amazed at is people feel they don't deserve to come in. Others are sicker than they are, and they reach a certain point. Or their wife says, you've been coughing for 7 years. Can you get it checked out finally? Or other health problems. Or their friend is getting care, and they say, you know what? I'm getting care. You were with me. Come in. So there are a variety of motivating factors, or they may just have had enough, and that's why they're coming in. Some people actually haven't heard about the programs, which is surprising to us, but they may not know it's out there, and so they're coming in now for the first time.
Okay. Mr. Deal?
Well, first of all, thank you all for being here. We do have to ask the hard questions. And the first question that comes to mind, I think, from somebody who's not from the immediate area affected, is that if we're asking the taxpayers of this country to pick up a tab that is estimated from what we have up to this point of at least $1 billion a year additional federal expenditures for a restricted group of individuals. The first question I think that comes to mind is, why do we have the stories such as Dr. Moline's illustration of, I believe, the carpenter who said that his workers' compensation claim was controverted and he was not being able to receive treatment based on the first line of providing treatment, which most people consider to be workers' compensation. Is the City of New York continuing, Mr. Holloway, to resist workers' compensation claims? And if you are, and you're saying that the conditions on which you're being asked to compensate are not compensable, why should the federal taxpayer pick up something the City of New York's not willing to pay for?
Well, the answer to that question has a couple of elements to it. First, when it comes down to individual workers' compensation claims, yes, there are cases that are 9/11 related that are controverted in the workers' compensation parlance by the city, but the reason for that is really, and Dr. Milius, I think, will jump in later, but the reason for that is that the workers' compensation system itself is not equipped to deal particularly well with these types of claims. The issues that we're dealing with 9/11 related illnesses at this point, they're late to arise, they are latent, and so important questions of causation and other issues arise in the context of these long-tail claims that make it difficult to resolve in one way or the other without an extended look at what's the medical evidence and so forth. And the reason for that is because the city does have an obligation through the workers' compensation system. You can't simply decide that it doesn't matter. You have to meet the standards in the statute. The city does have an obligation to, protect the public fisc. And so the way that the system is set up, it is poorly equipped to handle this. Now, New York State has made some changes in the workers' compensation law that address a few of these things, and one of those is that an extended period to put in for a claim so that you don't have the 2-year statute of limitations problem and some other things. But in the main, the system has some structural elements to it that make it difficult. Also, the system itself will compensate certain types of claims, but there are other people who are impacted. Uniformed services actually get their compensation through don't get their compensation through workers' compensation. It's a line of duty injury, but similar issues arise. And then community members, residents, and others who are impacted aren't eligible for workers' compensation. One other point is that the bill itself provides that in the event workers' compensation is recovered, or it's deemed that it will be likely to be recovered, that goes first in terms of paying for the claims, which we fully support. So that's a long answer, but.
Dr. Melius.
Can I just elaborate briefly? For the New York State workers' compensation systems required at least two pieces of legislation to amend that to make it possible at all for World Trade Center claims to be dealt with within that system. And had to do with statute of limitations and just the nature of the injury coming out or illness coming out of their work. And that has helped somewhat. I've recently served on a committee and on a task force for the state legislature to examine this whole issue. We're issuing a report which I believe will become public tomorrow on this. Made a number of recommendations for actually requiring further legislative changes we think that will make this system work better. The city of New York has actually agreed with those changes, even though it will in some ways, facilitate claims against the city of New York. So we're trying to work together to address that. It's just hard in a bureaucratic, legalistic system like the state workers' compensation system. And even when it does, for example, you have situations where someone's getting compensated for their asthma that may not provide help for their sinus condition or some other condition. That has to be, a separate claim and follow through on. So it's complicated and difficult. All the clinics that are involved in here, the centers of excellence, are also working very hard to assist people in filing claims. That was not, help was not available up until about 2 years ago. So there are efforts underway to try to improve that, and I believe the city and others are supporting that. But it is still going to be difficult. It will never be, I think, an adequate for this particular situation.
Dr. Moline.
For this particular gentleman, his claim was controverted, and eventually it took about 3 or 4 years. It was judged in his favor. That's a typical delay. During that 3 or 4 year period, when he was no longer able to work and he lost his health insurance, he had no avenue to get health care. He had, the program stepped in. We are now recouping the costs, and they will be offset as program income within the monies that we've received, so it'll allow us to extend the care that we provide. But, in his particular case, we tried to get diagnostic testing because he had such horrible reflux that he needed to have an endoscopy, a simple test where you look and to make sure that he didn't have something more serious going on. And that particular test was denied by workers' compensation. Turned out that he had the test, and they found some abnormalities that was paid for by the program. and it allow us to give him the appropriate treatment to get him better. It's, as a treating physician, it's, this program has allowed us to provide the care for people to make sure that they get better. What we also do is we fill out the necessary paperwork to make sure that compensation, if it's there, everyone gets the appropriate medical documentation that they need to make sure these claims go forward as well.
But I think your statements have illustrated the point that I'm making, is that somebody from the outside looking at this saying that if this kind of injury or problem resulting from exposure does not meet the definition of a work-related condition under workers' compensation law for the state of New York or the city of New York City, then why should we have a broader, all-encompassing definition that the federal taxpayer is required to pick up? And that's just a problem, and I think trying to refine the statute to address that as best we can is very important, because I think it is something that you have to convince other people that you're not just creating this big picnic basket that certain groups of individuals can come dip into the federal treasury through this mechanism. Let me ask one other practical thing, and that is I see the group that's here, and many of them have the New York Fire Department EMS shirts on, and one of the things that's been called to my attention is that apparently there is no provision for retirees or a retiree representative from that group to be on this advisory board that the statute creates. I would assume that you're going to have a large number of people who are in a retirement status that are going to be eligible on an ongoing basis for some of these benefits. Do any of you know why that retiree group would not have an advisory board member?
Well, yeah, let me answer that. So I chair the steering committee that I think is being referred to here. The steering committee was set up with a specific number of labor union representatives at the beginning, and along with representatives from all of the participating medical centers. Those representatives, the union's representatives, do represent retirees. The union I work with has at least 3 retiree organizations that are part of this program that are consulted. And we provide benefits to those retirees, health and pension. I believe all of the other unions involved do the same. There are many other other groups that potentially could be represented on the steering committee. There has to be some way of selecting those. The original selection was based on who was most involved in the program. It's certainly clear that the people in the retiree groups, as time goes by and more of these people age and get older, will be important in terms of representation. We need to work out a way for them to be involved in the program. There are other ways. Mount Sinai has its own advisory committee. The fire department does. Some of the other clinics do. Dr. Reibman has a program. And there are provisions in the legislation for additional people to be added to the steering committee. And so that would be worked out over time, but there are many groups to choose from, so it's not like there's one umbrella retiree group that one could select. It has to be looked at that. Some of those people with concerns I've met with and have offered to go out and meet with some more to talk, and because we want to make sure that their concerns are addressed, I think.
Thank you, Mr. Deal. Mr. Engel.
Thank you, Mr. Chairman. You know, I live about 8 miles from the World Trade Center. My district begins about 8 miles. And I remember about 5 days after 9/11, burnt pieces of paper falling from the sky into my district with my own eyes. I remember seeing that. And that's 8 miles away. So imagine the people who live right on top within a 1.5-mile radius. I understand the community program would help only people with a 1.5-mile radius. I want to talk a little bit about the World Trade Center related illnesses experienced by people living in the disaster area. That hasn't received as much public attention as those of first responders, but in many cases they're just as serious. And I don't take away anything from the first responders. I fight 100% for them, but there are also people in the area. This legislation provides medical monitoring and treatment services for community residents and workers affected by the 9/11 attacks, not just the responders. So, Dr. Reibman, can you tell us about the kinds of people that the community program treats and how they were exposed to the toxic dust from the World Trade Center collapse?
We have a variety of people, and we sort of group people by whether they were residents, whether they worked in the area, went to school in the area, or were there commuting, for example, people who were stuck in the tunnel at the time of the collapse. We also then look at people who were in the initial dust clouds of that day, or people who came back a week later. And what we're finding is that there's a great variety of difference in how people's health responded to these exposures, but that many people have many of the same illnesses that you're hearing described in the responders of chronic rhinosinusitis, that is sinus infections, nasal congestion, shortness of breath due to asthma or other lung diseases, as well as gastroesophageal reflux disorders, and clearly a lot of mental health issues.
Can you explain, can you describe the kind, you've talked a little bit about the kinds of illnesses these community members are suffering from as a result of their exposures. Are any of these illnesses, can you talk about the similarities similar to those of the responders? What I'm trying to get at is that I believe that it is just as serious to help the people living in the immediate area as well. And do you find that the first responders and the people in the area have had similar difficulties?
One of the, what you're raising is a very important question, which is how do we know whether these illnesses are World Trade Center related or not? And we don't always know, except by seeing many of the same symptoms over and over and over again in many of these people. The severity is clearly variable, and we have people who have very, very persistent sinus infection, sinus disease, who have required surgery for their sinuses on repeated occasions. We have people who, for example, used to run a marathon who are now on chronic medications. We have people who can no longer, who've had to have their offices moved because their cough was so irritating that their workmates couldn't sit next to them. So that there is clearly a variety of severity in these people and who they have. And we think that that's due in part to degree of exposure, people who were in the dust cloud, for example, on the first day, or people who had prolonged exposure, as well as individual response to these exposures.
Dr. Melius, can you explain what role private health insurance would play in the community program under this legislation?
Yes. Under the current legislation, that people that have coverage, there would be a billing mechanism set up for the government to be able to, through the clinics, the treating clinics, to recover the cost. So health insurance for those who have a non-work related health problem, health insurance would be essentially the first payer, and then what coverage, what was not covered by health insurance would be covered through the federal program.
Thank you. Can I ask you also, Dr. Melius, the legislation relies on centers of excellence for providing most of the monitoring and medical care for the program. Responders and community residents who qualify for the program can only receive services at the program's expense through these centers of excellence. Now, of course, these patients, the way I understand it, can continue to see their personal physicians, but if they want the monitoring and treatment services for the World Trade Center related conditions that the program offers them without charge, they'll have to use the centers of excellence. Is that true? Am I right? And in your testimony, you defend the continued use of the centers of excellence. So why do you think that we should continue to rely on these centers rather than allow individuals to use their personal physicians?
Yeah. Yes. The reason for relying on the centers is because given all that we don't know about what's going to happen to these people medically, and given the complications of diagnosing and treating them, we believe that a better quality overall medical care can be provided to them through these centers of excellence, rather than trying to rely on providing that same experience and medical information to their personal physicians. Now, I think both Dr. Reibman and Dr. Moline would tell you that they coordinate with the personal physicians so that who may be treating the same person for some unrelated health condition, heart disease or something that's not related to the World Trade Center. But I think it's been the experience of all the program that it has not worked well for people to go to their personal physicians because they just don't have the experience in handling these types of conditions, and the quality of care is not as good. Now, there are also provisions in the legislation to allow for the expansion of the centers of excellence, to bring in new centers and so forth. And I'm sure, in fact, at the judiciary hearing on March 31st, the police detective who had serious pulmonary disease and had developed before there was treatment program was being seen by another major medical center in New York City. And there's no reason that medical center could not become part of this program, and there's a number that have expressed interest. So I think we need to expand that out. I think it's also certainly true for the national program, people living in other parts of the country, that there be additional centers and additional physicians brought in. But it's trying to strike a balance between getting good care and ensuring that there's good follow-up and at the same time something that's convenient for and practical for the patients.
Dr. Moline, did you want to comment?
I think Mr. Torres actually told us why a center of excellence can be essential in his care. He was going to a wonderful physician on the outside, but when he was able to come to a center of excellence, we were able to make a connection between his illnesses because we've seen thousands of people like Mr. Torres with the same constellation of symptoms and know how to treat him in the same manner that we've treated thousands of others. One other issue related to not having centers of excellence is if we want to know what the ramifications were from a disaster, a man-made disaster, terrorist or otherwise. If the care is fragmented, if if everyone is not receiving centralized care in a number of centers, then we'll have no way of knowing the true scope of illnesses. There will be no way of being able to scientifically say that exposures of this sort can cause health problems, so that in 20 years when something else happens, we can say to every doctor is going to know, because it will have been in the literature, that these are the things you do first. And we're in this not only to treat people now, but to be able to inform the doctors and the people who might have ailments going forward.
Mr. Torres, would you want to comment on that?
Yes, just like the doctor said, the only way I could comment that it was on my experience. I was going to my doctor almost a year, and I had a CAT scan done from my neck down, and they never found nothing wrong with my throat, but I was losing my voice. When I went to the monitoring program, when they were evaluating me, one of the doctors there said, well, Mr. Torres, if you have GERD, acid reflux, and you're having a breathing problem, a lot of people need to see an EMT doctor. So we're going to make an appointment for you. And they sent me to a throat doctor. And when they put the scope down, there was a polyp, a mass, in my throat, which wasn't picked up by a CAT scan, which wasn't picked up by my doctor, which, this might sound strange, was a very happy moment for me because I got an answer out of a year of no answers, and I am one of those males that don't like going to the doctors. I am one of those males that my wife had to force me to go to the doctor, and I was so happy to finally get an answer because I was tired of going to the doctor and coming back home and not knowing what was wrong. But I knew there was something wrong.
Well, thank you. It's very good to hear firsthand experiences, Mr. Torres, Mr. Holloway, and other people. Let me ask one final question. How does the legislation, and perhaps Dr. Melius would be the best to answer this, but anybody else can, how does the legislation ensure that the care received through a center of excellence is coordinated with the care received by a responder or community resident from his or her personal physician? Mr. Torres talked about how he wasn't getting answers, but if someone has gone to a personal physician, how is it coordinated with the Center of Excellence? How does the legislation ensure that it's coordinated?
I think there are no specific provisions in the legislation for that, but the normal way that, the usual way that these physicians operate in these centers is they focus on World Trade Center related conditions. So they're focused on the sinus, on the lung disease and so forth. When there are other personal health problems that people may have, existing conditions or something else develops that's non-World Trade Center related, then as any specialist would, they would refer back to the primary care physician. They would be building off what medical records, what medical information, they would be in contact with that personal physician in terms of either doing referral or direct referral back for further care. And I think that's routine in the operation of the Sinai program and the Bellevue program.
Right,
Yeah.
but what about someone who gets care from a private physician and now is going to the Center of Excellence, as Mr. Torres said, went to a private physician first, the Center of Excellence. What is the coordination? Does the private physician reach out to the center? Would the center reach out to the physician? How would we know that it's not duplicative? That's the kind of question I'm asking.
There's a variety of ways at Mount Sinai we do this. First of all, every patient who's in a monitoring program, whether it's the fire department's monitoring program or the consortium monitoring program, gets a results letter to bring with them to their doctor, and they get a copy of all of their test findings. We also ask if they would like copies sent to their doctor. If they give us authorization, then we send copies of all of this information to their doctor. If they're symptomatic and receiving care, all of our physicians reach out to these doctors to make sure that we aren't going at cross purposes. We're not both prescribing the same medication or medications that might counteract each other, that we're all on the same page in providing the best care. We're working in many ways as a consultant would to a primary care physician. We're providing care for a number of specialized or a number of conditions in addition to going to your family doctor for your routine checkup. You'd be referred to, if you had a back problem, you would refer to the orthopedic surgeon. The orthopedic surgeon would communicate back to the family doctor to say, yes, this is what I saw. That's how we work with the private doctor.
Well, thank you, Dr. Molina, and thank you for all the good work you do. And thank everyone. I want to thank everyone on the panel for the good work you do and for the people who have the courage to make their public struggles, their personal struggles, to share them with us. It's very important that the country understands, as so many people have said, that this is a problem affecting all of us, and we need a federal response, and we need that's why we need this bill. New York happened to be the place where the terrorists attacked, but the terrorists attacked New York because of the symbol of New York and what it means, and therefore we have a tremendous responsibility. And those doctors who are on the front lines, you indeed are first responders because you are on the front lines, and those people with the courage to tell us their stories are really making such great progress. And finally, Mr. Chairman, I want to commend you because I'm on this subcommittee, and there are so many related health concerns that we have in this country. And you and I have spoken many times about the need to have this hearing, and you have always been positive and helpful. And obviously this wouldn't have happened today without your leadership in this very, very important matter. And you and I have discussed this, and I'm confident with you as chairman, we're going to finally move forward and break through and pass this legislation, which is so desperately needed. So thank you again, Mr. Chairman. I want to state on the record how helpful you've been.
Well, thank you, and we do intend to move forward. Mr. Weiner.
Thank you, Mr. Pallone, and I want to echo the remarks of Mr. Engel. You and Mr. Deal have been very helpful in moving this forward, and it reminds us that when the first victim compensation bill was passed, it was unanimous or nearly unanimous, the notion that people who perished in what was essentially an act of war deserved not only our gratitude, but they also deserved a quick dispensation of the needs of their surviving family members. And the universe of people that we talk about today, in fact, many of them are people who are dying by degrees because of that day. And as has been remarked in the past, if we knew then that people would be dying years later, there's no doubt in my mind that we would have, in a bipartisan fashion, changed the language of the bill to make sure that the Victim Compensation Fund took into account people like Mr. Torres. And Mr. Torres, who speaks for many people, some of whom are here, many of whom have gone on with their lives, some of whom unfortunately have perished, many of whom are sick, they responded that day because it was a combination of their job and their sense of their obligation to their neighbors. They went without being asked to sign forms. They didn't go with an instruction book. If anything, the advice they were getting from many officials, as we now know, was wrong. We had the head of the EPA at the time saying the air was just fine, and people were handing them equipment that you wouldn't use to paint your apartment, and they were being asked to wear it when they were dealing with the toxic soup that has been described here as unprecedented. And but let me just ask a question that perhaps can refocus us on the broader question. The people with doctors in front of your name, is there any doubt in your mind that people today are dying because of the attacks on September 11th and their proximity to that attack?
I think there are people who are very, very sick because of September 11th and their proximity at that time. We certainly hope we can prevent them from dying.
Dr. Milius, is there any doubt in your mind that there are people who are dying by degrees because of that attack?
Absolutely not.
Dr. Molina, any doubt in your mind that there are people who are dying by degrees because of that attack?
Absolutely not.
And Dr. Molina, I want to take a moment to thank you. I've seen your work secondhand as folks very close to me have turned to you for care and have received it. One of the questions that has come up is that whether or not, in addition to us providing a service to the people who are sick, we also send a message to future generations of people like Mr. Torres that if they do run into the aftermath of these things and try to help out, that we're going to be there for them just as we would if they were soldiers. Mr. Torres, I know that you have said in a couple of places that you don't regret anything about the way you acted and your colleagues, the service that you provided. But certainly there must be a time in the still of the night where you think, boy, was it worth it? Are you concerned that if you're seeing someone else and they say to you, you know, it sounds like you got really sick from being there on the job and now the federal government isn't responding, that we might be in a circumstance in future attacks where people start to have second thoughts about whether or not they should go into that place when called by their neighbors. Do you think about that at all, that, you know, that all that you've gone through, and you must have a lot of brothers and sisters who have situations that are like yours, they must sometimes say to themselves, you know what, if I knew then what I know now, maybe I wouldn't have raced there to be of help.
Yeah, that conversation comes up a lot with at the workplace. It comes up just 2 days ago when I was telling my wife about this committee. She asked the same question: what will happen if they don't pass this bill? Will people go back out there and help again? I have a brother who's a fireman in Jersey City. He was out there too, working. And we talk about it. He would go out there if he wasn't a fireman. I would go out there again. I would go out there. Hopefully, God willing, we never have to, but there's not a doubt in my mind. Even with the illness, I don't regret what I did. I did it because it was the right thing to do. So to answer your question, likely, yes, some people do have that in their mind, but I think human beings in nature, when something tragic happens, they respond.
Right.
And we saw that at the World Trade Center, because it wasn't firemen and policemen there alone. There was a lot of other people working, male, women, old, young. Jersey City had a chain gang filling up tugboats from young people, high school, grammar school, anybody helping. I want to believe that they will come out again.
Well, I believe they will, and we should be there for them now. Let me just conclude with just this one question. There was some opposition that has been voiced about the idea that we don't know for sure when someone comes in whether they are afflicted by the effects of ground zero dust and they're being in that environment or something else. You know, someone comes in with a headache, it could be from anything. As you accumulate a larger database of information, see more clients and do more research, are you reaching the point where you can say, perhaps not with metaphysical certitude, but some certainty when you're dealing with someone who's come before you because of a 9/11 related thing? There have been some concerns raised. Well, it sounds like we have this catch-all situation. If anyone can show they're anywhere nearby at any time, they could come in, and it might have nothing to do with the 9/11 dust. If we can just start perhaps with with Dr. Moline, and then we'll go down the line. Do you have some sense now that you've got a sufficient body of knowledge, and as it grows, that you can allay the fears of some of my colleagues that this isn't entirely open-ended, that you can tell we now have some foundation which to draw a conclusion about who is made ill by the effects of 9/11?
Well, I think if you look at the medical studies that have come out, and studies come out from the fire department, from the police department, from the consortium at that Mount Sinai coordinates, from Dr. Reidman's, everyone has the same numbers. You look at objective measures like pulmonary function tests. 28% have abnormal pulmonary function tests, whether it's police officers in a separate study, whether it's a group of 10,000 folks that we reported on, whether it's folks from fire department or from Dr. Reidman. When you see this constellation of symptoms in thousands upon thousands of people, that I think there can be no doubt that these exposures were the cause of many of the ailments we're seeing, if not the specific ailments that...
Yeah, I'm asking the inverse of that. I'm asking, we know about the population as a whole. The question is individual citizens that come in and say, okay, I want to take advantage of the provisions of this bill. I am made sick by 9/11. Do you have the ability to be able to allay the concerns of some of my colleagues that say, oh, you don't really know, it could have been from something, they could have had something predated that could have, you know, that you could be seeing? Are you at a point now that when you see someone, you look at the combination of where that person was, what kind of symptoms they have, their profile as, you know, are you at a pretty comfortable place and that you can say, yeah, we're pretty sure, we don't know with absolute certainty, we're pretty sure this is someone who's made sick by September 11th?
What you're describing is my specialty, which is occupational medicine, which is a specialty.
You should testify before a hearing or something. You would be perfect.
Thank you. That's what we do. We say, what do you do? Where were you? What were you exposed to? And find out what was your health like before you had these things. And I do that every time I see a patient. I was going to be taking care of patients this afternoon, but I'll be seeing them tomorrow morning. Those are the questions that all of them have been posed by me to find out on an individual basis. Sure, we will publish on the aggregate, but on an individual basis, how were you on September 10th? What was your medical history before that? And now, when did you begin to have symptoms? What were you doing? Where were you? What other things have intervened in between? It might be something else. It might not be. How are all of these things affecting your health now?
And so you have some confidence.
We have
And
confidence.
Dr. Milius, did you have a similar sense that you pretty much, you can now spot it when you see it and take a look at it?
I don't provide the direct care, but I think what I would add to what Dr. Moline said is remember that, again, it's why we have centers of excellence, is to have standardized approaches for addressing and examining people. So they use the same questionnaires, the same types of testing, so that's standardized in everybody. And as I work with these physicians, they pick up on they understand that issue, and they've developed so much experience that I'm very confident.
Well, thank you.
in-
Mr. Chairman, I have a vote in the other markup, and I want to thank the panel very much.
Thank you. We're about to conclude, but I did want to ask one or two more questions with the support here of my ranking member. I thought you had said earlier, just following up on what Mr. Weiner said, I thought you had said earlier, Dr. Malayas, that you actually have a certification of some sort that a person had a World Trade Center disease or disorder. Did I
Yeah.
misunderstood?
No. Right now, what I was referring to earlier was in the legislation, there's now the requirement, which is not strictly in place now, sort of administratively, but going forward, that, say, Dr. Moline, Dr. Reibman would first, they would say that when a person's eligible for the program, secondly, that they have a World Trade Center-related condition, and so forth. They would do that. There would then be a certification by NIOSH, or whoever is administering the federal agency, that, sort of reviewing that, making sure that it followed all the procedures, that it was correct.
So essentially, I mean, maybe certification isn't the word, but essentially, you would say this person has the disorder and they're eligible for the program, and
Yeah.
if they didn't meet those criteria, you wouldn't treat them anymore, in
Correct.
theory.
Correct. And that is currently happening now in the program.
Oh, you do
If
get
someone is-
people that come in that you decide don't have the disorder, and then you turn them away, essentially?
Right. It's a limited number, but there are people, and we've actually worked out among all the participating centers of excellence a program to sort of make sure that in their process, as patients come in, because everyone's handled slightly differently, that if they're suspicious that someone's not really eligible, or that they have a way of more intensively following up, demanding that there be more documentation that they actually work there, and that process is working because I get calls from them, and we talk about it at the steering committee meetings and so forth. And certainly, with people coming in now, 7 years later, I think we have to be more careful about it, though, again, it's not to say that the vast majority of the people coming in
I
are.
mean, most people don't show up if they really don't have a problem.
Exactly,
but-
yeah.
All right, then my last question is this, and I kind of went back to the beginning. In terms of the need for a permanent program and authorization, which is what we're all about. I mean, let me preface that by saying, we're an authorizing committee,
Yeah.
so we don't particularly like the fact that you operate without a permanent authorization, because we don't like to do business that way. And certainly, for us, that's not the way we do things. But the question really is, without the permanent authorization, again, sort of being the devil's advocate, I assume that you've had problems operating the way you are, and that there's some inherent benefit in having a permanent authorization. If any of you'd like to comment on it, I think that might be important.
Then I'll follow up.
It's working in a clinical setting where there's uncertain funding year to year. I reach a certain point where I begin to draft the letter that's going to go out to say we can't provide the care that you've been receiving to all the patients. We can't guarantee that they will get the services that they need without having a permanent solution. We are intensely grateful, immeasurably grateful for the monies that have been appropriated for us. And it's year-to-year funding. I mean, we have a staff that we're seeing thousands of patients a year at Mount Sinai. We have an infrastructure that's developed. It's very hard when you don't know if you're able to sustain that every year, and you're worried, is this going to be possible? Am I going to have to start from scratch again where I have this expertise that I've built up? And that's been one of the challenges in trying to make sure that we have the resources so that we know that if we do have to expand, if there are more people coming in or there are new illnesses, that we'll be able to handle that when we're worried about whether we're even going to have funding for the next year available.
Anyone else want to comment? Because I think that is kind of important here.
I would like to agree just to say that it's very important to be able to recruit people, to train people, to get people with experience so that they can answer just the questions you're asking. How do you know this is World Trade Center? Is this what we've seen before? How are we going to approach it? And to have to not know whether you're going to be able to retain people, to have to retrain people all the time makes the program very difficult.
Mr. Holloway.
And just on, we're talking in part about programs that have appropriations. You have to come back and do it from year to year. There are also, from the city's perspective, a number of programs that are primarily funded by the city. And although we've gotten some of the, recently from NIOSH, some money appropriated there, the HHC program right now is actually running at a deficit. One of the other programs that we didn't talk about in detail is a mental health program, which actually does reimbursement for mental health services that is funded in the bill, also operating at a deficit. So for some of these programs, you know, the city, as I said, didn't wait for Congress to act for us to meet the needs that we found when we dug into this. But you know, the program will be subject to the vagaries of the very, very difficult budget choices that the city has to make about all of the programs that it provides. And so, you know, this isn't just a matter of coming back and everybody testifying every year about an appropriation. You know, we would really like to see this go past the point where it's a question whether these programs are going to run, and we do feel that it's important that with the city contributing, it is a national responsibility.
Okay, thank you.
Can I just add, I think it's also very important for the participants in the program, and one good recent example is one of the individuals, a firefighter, just recently underwent a lung transplant. And he and his family were asked, well, do you want, who should cover this? Because if it's covered out of this program, it was World Trade Center related, then what's going to happen in the future? Because that individual is going to be on, you know, significant medications for the rest of his life, which we hope is a long one, and who's going to be able to pay for that going forward? So knowing that this program had long-term funding would have made that decision much more easier for that individual. And I think for everybody involved here, they all have to wonder what's going to happen with, you know, with their health insurance cover, who's going to take care of them down the future. It also has implications for the Victims' Compensation Fund portion of this.
Sure. Mr. Deal.
Well, my information is that CDC had, I think, $180 million carried over that was appropriated for FY 2009, and they've obligated just over $16 million through the end of March of 09. And my understanding is that based on those currently appropriated funds, that there appears to be adequate funding through 2010. So that carryover money, I think, does make a difference.
Could I?
You know, I mean, we obviously, you know, you still have to go through the appropriations process every year, but there's a big difference in terms of having something that's permanently authorized that you can count on as, you know, as being authorized versus having to, you know, come back every year for the money. We can't avoid that. That's just the annual process. Did you want to add anything? Otherwise, we're going to conclude.
Just one thing to Congressman's point. There is money that carries over. It actually took NIOSH and CDC for whatever reason many months to actually get an RFP out on the street and create a vehicle to access that funding that had been appropriated. And in fact, after this hearing today, I'll be going to NIOSH to talk about how we can do a better job ensuring that the money that's already been appropriated to deal with this is best used. So any help you can provide would be appreciated.
Sure. All right. Well, thank you very much. You may get additional questions within the next 10 days that members can submit for the record, and then you'd respond to us, and the clerk would notify you about that. But I just wanted to thank you. Well, I thought this was a very good analysis, and as I said, we do intend to move forward with the legislation. So without objection, this meeting of the subcommittee is adjourned. Thank you.